Hi, and welcome back. This is now lecture 3 in chapter 5. We are going to talk about health and wellness. So this is sort of a continuation. After this lecture, then we'll get into some procedures, but let's just get started here. So cardiac assessment, every organ system gets assessed, right? We've talked about it throughout this semester, and the cardiovascular system is no different. The very first rule of thumb for any healthcare practitioner is observation, right? So observation, really just looking at the patient, getting an idea of generally, and without a lot of specific details, how well are they doing. Some organ systems are easier to observe. So for example, it doesn't take a lot of expertise to be able to tell if someone has a lot of respiratory distress, if they're having trouble breathing. Cardiac assessment really does rely primarily on sort of more fine details, but you can at least look at someone and observe with your eyes their skin tone, sort of their level of energy, and some things that are demonstrated by a functioning good cardiovascular system. But what we're going to do is primarily more detailed. So auscultation. So you're using stethoscopes to listen for sounds. Some sounds are easier to hear than other sounds. Lung sounds are pretty easy to get the hang of. Bowel sounds are not terribly complicated. Heart sounds require a lot more finesse, and they take a lot more practice. And in all honesty, too, it can take anywhere between 30 seconds and a full minute to really thoroughly assess the heart sounds with a stethoscope. So what we're going to hear with a normal, healthy heart is the S1. That's the first sound. You already know what a heartbeat sounds like if you've watched a horror movie. You've heard the thump, 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 thump in the soundtrack. So you already sort of know what a heartbeat sounds like, but it's a little different with a stethoscope. The first sound, the S1, is the lub noise. And this is really just the noise that's made when the valves close during systole. And remember, systole is that period of ejection of the blood. So with a lot of force, that's the S1. The S2 then is the dub sound, lub dub, lub dub, lub dub. The S2 then is closing of the valves during diastole. So that is when the valves close just prior to relaxation. That is what you want to hear, and those are the hallmark characteristics of a nice, healthy heart. So that's what you're listening for. You're listening for the valves when you auscultate the heart. There are abnormal heart sounds that can be heard, depending on illnesses and things like that. But for our purposes for this class, we're just going to talk about the S1 and the S2, so the lub-dub sounds. Assessing the cardiac function of someone involves taking a pulse. The pulse gives us 2 clues. How fast is the heart beating? And sort of sometimes, if you're really good at assessing this, you can find regularity too. So you expect to have a regular, nice, rhythmic pulse. But the pulse is primarily used to determine the rate of beating. And we'll talk a little bit more in this lecture about when the heart beats too fast or too slow, but we want to have a pulse between 60 and 100 beats a minute. That's normal, and there's going to be variations in there. Your pulse will go up when you're on the treadmill. Your pulse will go down when you sleep, for example. And blood pressure. So blood pressure, we are measuring the amount of pressure that the heart has to use to eject the blood and how much pressure there is at rest. So the blood pressure can be described, and it is described, as the systolic pressure over the diastolic pressure. You will never hear somebody's blood pressure as a single number, right? It's always, and typically the gold standard is 120 over 80. So 120 represents the systolic pressure, and 80 represents the diastolic pressure. And how are you going to remember this? I have a way. Don't worry. Don't get overwhelmed by this, and don't let us stress you out. You're going to remember this as a fraction, right? So there's one number over another number. The top number is systole, so the pressure when the heart contracts and ejects the blood out of the ventricles. So systolic pressure is going to be higher. So that's going to be your upper number. The diastolic number, we know the diastole is the pressure at rest, and so that's going to be a lower number. 120/80 is what I just said a minute ago. You've probably never heard anybody say, I was at the doctor today and they said my blood pressure was 80/120. It's always a higher number over a lower number. And the trick to remembering this is D for diastolic is the down number or the dividend in this fraction. So remember that diastolic is the lower number because it's at rest, and it's the down number. And that will help you sort of to remember which one we're worrying about here and which number means what. So there's my example, 120/80, and that's how you would see it recorded in a patient's medical records. Now we can talk about blood pressure as hypertension and hypotension, so hyper being too much. And there's a lot of resources worldwide put into managing hypertension, and we'll talk a little bit later in this lecture about why hypertension is bad. But hypertension is sort of different levels. In 2017, the parameters were changed a little bit, and so now we talk about elevated blood pressure as being a systolic of 120/129/80. So it's really not truly hypertension yet, but this would be sort of evaluated as worrisome, right? You're trending upward. And before I go any further, just a word of caution. Hypertension is not one elevated blood pressure reading. For example, if you slam your finger in the car door, your blood pressure is going to go up. So if you were to just slam your finger in the car door and go into CVS and use their blood pressure machine, you would probably find that you have an elevated blood pressure. We're talking about hypertension that is over a period and it's a consistent elevation. So we would just talk about somebody being elevated if their systolic was in the 120/129 range, but their diastolic pressure was normal. Hypertension then gets divided into two stages. Stage 1 is the systolic pressure is 130/139, or the diastolic pressure is 80/89. Definitely trending upwards here. Hypertension stage 2 is that systolic pressure is greater than 140 and the diastolic is greater than 90. Either or. And so usually hypertension stage 2, when it's consistent, this is the point where physicians will start talking about adding various antihypertensive medications for that patient to get their pressure down. You typically can't feel your blood pressure. There are people who have chronic hypertension that's poorly controlled. They can sometimes tell you when their blood pressure is getting high, but by and large, you just really, if you're sitting right now listening to this lecture, you can't possibly tell me what your blood pressure is. You have to actually measure it. And we'll talk a little bit later in this lecture and in some other lectures about what happens to the body in the presence of continued chronic hypertension. But these are the measurements. And don't get freaked out about the measurements. Just a word to the wise. I just want you to understand, I'm not going to really ask you about the actual numbers. I just want you to get an idea of these parameters will increase, and with each increase, then it becomes more worrisome to the patient. Hypotension then is just the opposite, hypo being below. So hypotension is low blood pressure. And interestingly enough, there are no parameters for hypotension. Hypotension is really very subjective, so the patient has to say how do they feel. Some people just manage with very low blood pressure. So there are some people out there that will walk around with the blood pressures of 100/60, which is pretty low, and they'll feel fine, and their bodies compensate, and that's how they always are. There will be some people who, if they have a blood pressure of 100/60, will develop symptoms. Symptoms such as lightheadedness, syncope, lightheadedness upon quick standing, sometimes even a brief loss of consciousness. So hypotension is really subjective and it's in the eyes of the beholder. So if a patient has complaints of hypotension and their blood pressure is really low, that's the point you treat them. The body can compensate for a lot of things, and low blood pressure is one of those things typically. So let's talk a little bit about myocardial diseases. The first one being angina. And there are different kinds of angina, but I want to tell you just in general what angina is. So if there is occlusion of coronary arteries, so plaque deposits or perhaps even a blood clot that is causing a reduced blood flow through the coronary arteries, this will create chest pain. Angina is chest pain that is not resulting in a loss or death of cardiac tissue. So typically people with angina will have some type of reduced blood flow to the myocardium, and they will be able to go about their daily business, but they will have an exertion threshold where they will start to develop chest pain. So for example, sometimes people with angina will be able to, do housework and cook dinner and things like that, but if they go and mow the grass, that might be too much effort, and then they will start to have chest pain. The key finding here is that angina is chest pain without death of myocardial tissue, which we'll talk about in a minute. Cardiomyopathy is a very, very broad term. Pathy, disease, myo, muscle, and cardia for the heart. So this is a very broad category that's talking about diseases that affect the muscle of the heart. Cardiomegaly is a little more specific. We know megaly is enlargement, so this is an enlarged heart. So and this is primarily an enlarged myocardium, right? So the muscle. So people like big muscles. And if you go to the gym, you think, I want to have big pecs, right? That kind of thing. And so you could logically extend that thinking and think, great, a big heart muscle would be awesome because then I could pump better and my body would be happier and healthier. But at some point, if that myocardium becomes enlarged because it is muscle, it can become too heavy and it will actually hinder effective pumping. So cardiomegaly in an enlarged heart has a lot of very serious consequences. Now, a myocardial infarction, I will refer to this as an MI, and it is known by the lay term a heart attack. So a myocardial infarction is where there is occlusion to coronary arteries, and we talked about those four main coronary arteries. So any of the coronary arteries become included either by plaque or by a blood clot, and blood flow is significantly reduced. What happens to tissue when it doesn't get adequate blood flow? It dies. And so a myocardial infarction is an area of dead tissue because of a lack of blood flow. And we'll talk a little bit more about this, especially when we get to procedures. So myocardial infarction is a heart attack. Some of them are fatal, and it depends on where in those coronary arteries the occlusion occurs. So if it's one of the main four coronary arteries, it's going to affect a significant amount of tissue, and it's usually not survivable. A smaller artery will have a smaller area of tissue that's affected, and people do survive their myocardial infarctions. So what happens though with a myocardial infarction that is survived is that congestive heart failure can happen. So this is sort of a long-term consequence of having an MI. What happens is that area of dead tissue in the myocardium, it's there, but it can't pump, it can't do anything. It's just dead weight. And so what will happen is if it's a significant amount of tissue, the heart will become weakened, and it will affect the blood flow to either of those circulatory systems. So if I had a right-sided myocardial infarction, that right ventricle is going to be weakened and it won't pump very hard. So my systolic pressure will go down and my heart just won't be able to do it. So then I will end up with congestion. And when we talk about congestion, we're not talking about like nasal congestion or chest congestion. We are talking about changes in pressures that happen in the circulatory system. So the right side of my heart, if it pumps into my pulmonary circulation, I'm going to have pulmonary symptoms. If I have left-sided heart failure, the left side of my heart pumps to my peripheral circulation, I'm going to have symptoms there. Endocarditis is inflammation of that inner lining of the heart. Mitral valve prolapse is the most common valve prolapse. Any of the valves can fail. In this case, a mitral valve prolapse will result that mitral valve does not close enough. And so then every time there is systole, every time there's systole, there will be a regurgitation of blood in the wrong direction. Those valves are put in place so keeping the whole system as a one-way system. So then instead of the lub-dub, you'll hear a little bit of a whoosh, a whoosh, a whoosh, and you can hear the blood flowing in the wrong direction during ejection. So the treatment for that is a valvuloplasty, so repairing that valve or putting in an artificial valve. And again, the mitral valve is most common, but it can happen to any of the valves. Pericarditis, then, the endo is the inside of the heart, peri is around the heart. Pericarditis, then, is infection that involves the outer kind of layer of the heart, around the heart. And pericarditis can happen, endocarditis and pericarditis both can happen because of either viral or bacterial infections, and bacterial infections are more common. In the case of pericarditis, sometimes this is a consequence of IV drug abuse because shared needles allow the introduction of bacteria into the bloodstream, and so sometimes people who are IV drug abusers will develop pericarditis. Conduction disorders. We talked about that beautiful conduction system, and it's huge, right? There are all sorts of things that could go wrong in the conduction system. We could spend an entire semester talking about conduction disorders, and I'm sure you don't want that, so I've really got it narrowed down to the common ones. And bradycardia is the first one. So we would say bradycardia, Brady being slow, would be less than 60 heartbeats a minute. You might actually experience bradycardia when you sleep, and that's not abnormal. World-class athletes who are extremely fit will have bradycardia. They'll have very slow resting heart rates. So it isn't necessarily a bad thing, but if you have bradycardia when you're awake, and in the case of bradycardia, sometimes if the SA node doesn't want to work and the AV node has to kick in, the AV node can't respond to the demands of my body. My AV node is going to go somewhere in the 40s. And so, and we'll get to this again in a second, but that could be very bad bradycardia. Tachy then is the opposite. It is fast. So tachycardia greater than 100 beats a minute. If I'm on the treadmill and I'm running, I expect to have tachycardia, right? If I'm asleep and my heart rate's 110 beats a minute, becomes worrisome then, and that's very questionable. So tachycardia in and of itself isn't bad, but both bradycardia and tachycardia are going to depend on circumstances. Now, dysrhythmia is a very general term. So dys meaning broken, rhythmia, or a condition of pertaining to a rhythm. So dysrhythmia is any time that this lub-dub, lub-dub, lub-dub doesn't occur because that whole pathway, something got a little wrong. So you can have flutter, and flutter is a heart rate that is very fast, tachycardic in nature. So we're talking about really fast. We're talking about upwards of upper hundreds and 200, and it's very fast, but it's a little coordinated. Then there's fibrillation, and I'm going to explain sort of the problems with these in a second. Fibrillation is very, very fast again, upper 100s, 200s, but it's very uncoordinated. So it's almost like an asynchronous beat. Flutter and fibrillation are both bad because they're very fast. The chambers require some time to fill with blood. And so if you have this where it's happening really fast, the chambers can't fill adequately, so there's very, very low cardiac output. Fibrillation becomes more dangerous, and you will see commercials for drugs for atrial fibrillation. When it's the ventricle that's in a state of fibrillation, it's really bad because it's very uncoordinated, and the ventricle is going to eject and push all that blood into the two circulatory systems, right? And so if it's not filling with blood and it's behaving in an uncoordinated manner, this is not consistent with life. So ventricular fibrillation is really bad news. I sort of hinted a second ago to about 6 sinus syndrome. So if the SA node decides not to work and the AV node kicks in, I'm going to have a bradycardia regardless of circumstances. So I'm going to be bradycardic when I'm sleeping, but I'm also going to be bradycardic when I'm running for the bus. So the 6 sinus syndrome is where the SA node is not working at all or is working very inconsistently, and the AV node's trying to pick up. The treatment for this is a pacemaker. The pacemaker can kick in, and every time the SA node doesn't do its job, the pacemaker can then initiate the rhythm. And then asystole. So we know that systole is that period of time where the chamber is contracting and ejecting blood, and we know that the prefix A is without. And you already know asystole. You've seen this on Grey's Anatomy or some other medical dramas where there is just a flat line and that noise, right? You don't have to go to medical school to know that that is not a good rhythm. So asystole is the absence of the ejection. So let's talk a little bit about some blood vessel disorders. An aneurysm. An aneurysm can happen anywhere. We've sort of been limiting ourselves to the heart, but these are just anywhere throughout the body. And an aneurysm is where there's a thinning and a weakening of an arterial wall. And that might be something that was congenital, present at birth. It might just develop over time. But in the presence of hypertension, that aneurysm can rupture because that part of the wall is weakened and thin. And so if you've ever seen a kid's birthday party clown make a balloon animal and they twist it, and sometimes the balloon becomes very, very thin and translucent, it's almost what I would sort of describe as an aneurysm. So the wall becomes very thin and weak. An aneurysm that in its worst case scenario would rupture, and depending on the location could result in serious deficits or death. So the treatment for an aneurysm is either surgery to go in and repair that weakened wall, sometimes bed rest and medication. There are different types of aneurysms. Arteriosclerosis. Osis is an abnormal condition, sclero is hardening, and arterio. So arteriosclerosis is it can be referenced by the everyday term hardening of the arteries. And so this is where the arteries, remember the arteries can respond, right? Increase and decrease blood pressure, and they're very responsive to the body's needs. But the arteries become hard because they have a deposit of plaque on them. Coronary artery disease is arteriosclerosis that's specific to the coronary arteries. So either arteriosclerosis or coronary artery disease. We talked about hypertension. So if you have continued, prolonged, consistent hypertension, what happens is that excessive pressure as the heart ejects the blood from the ventricles will eventually cause these little micro tears in the arteries. And these little tiny micro tears are awesome spots for plaque to deposit. Also, they're great spots for clots to form. And so this is the reason in terms of the heart that high blood pressure is bad. We'll talk about other organ systems later in the semester. So then with that hypertension, you can have a clot or plaque deposit start. Phlebitis is itis, inflammation of phlebo, which is vein, right? So phlebitis happens, it can happen for a couple of different reasons, but as a nurse, my most common exposure to phlebitis is from IVs. So an IV is always placed in a vein, not an artery. There's one exception that we won't talk about here. But right, if you just get a regular IV because you're sick and you're in the emergency room, they're putting that in a vein. And sometimes certain medications can be very, very irritating to veins. So that's sometimes what will cause phlebitis. Varicose veins, remember before in the earlier lecture I talked about how veins have valves in them to help with blood return. Well, varicose veins are nothing more than sort of swollen and enlarged valves in the veins. And so this is sort of the common problem of people who spend their professional lives on their feet. Waitresses, toll booth operators, I'm sorry to say nurses, so people who stand for a very long period of time. Pregnant women also are famous for sort of having varicose veins because that as the baby grows, it creates dependent pressure on the legs. And varicose veins can happen anywhere, but you most commonly find them in the legs. And they become sort of swollen and enlarged and very uncomfortable, in addition to not being very cosmetic. So that's it. We are going to move into lecture 4 now. We have a lot of procedures to talk about. But as always, I love your questions, and anytime something doesn't make sense, I would love to hear from you, and so please ask me questions. Talk to you soon.